Thank you guys for being here once again to hear about some medical knowledge which you never thought you would one day have to understand and learn. But be that as it may, there's a lot of medical information with respect to fertility, as you know. So we have here 5 experts that work in the field of reproductive endocrinology who will discuss several aspects in the process, from egg donation, embryo transfer, and pregnancy rates and PGS and all that stuff we discussed yesterday. So thank you for our speakers. We have Dr. John Norian. They're all from California, actually. Dr. Susanna Park from San Diego Fertility Center. Dr. Guy Wengler from California Fertility Partners, Dr. Kumar from Western Fertility Institute, and Dr. Shriyak from Pacific Fertility Center. So thank you guys for being here. So we're going to start first with Dr. Ringler, who's going to discuss egg donor selection, an important part of the process. So thank you, Dr. Norian.
Good morning, everyone. So, very happy to be here to talk to you about egg donor selection, which I think is one of the most important parts of the process for you. I'm sorry. Because not only do her genetics provide the genetics of your child, but her egg quality has a significant impact on embryo quality and ultimate success rates. So please take your time in selecting your donor. I'm sure when you selected your partner or husband, you didn't, check off the first guy that was cute at the other side of the bar. You took your time. This is a huge emotional investment. And the good news is there's a wide diversity of egg donor candidates available, especially here in California. You can find whatever you're looking for, and you should never feel like you have to settle, like, oh my God, I have 3 candidates, I guess this one is the best. You should wait until you find someone not only that you like, but you're really excited about, you really feel good about. And you can find anyone of different ethnic backgrounds, hair color, eye color, educational background. So you want to wait until you find someone that you just have a response to. Yes, I like her. And what I ask my patients to do is to send me 2 or 3 profiles of your top choices. Then I'll go through medically and see if some look like better candidates today. And what my goal today is just to walk you through the process of things to help you look for when you're selecting an egg donor. First question, do you want to know the donor? Do you want to meet her, or do you want to be closed and anonymous? I had drinks last night with former patients of mine who have a 4-month-old son. They spoke yesterday on a panel, and they feel so good about the fact that they know who their egg donor is. Their egg donor has met their son, and so they have a really positive feeling, positive image about who provided the eggs for their son. I have other patients who really prefer to be anonymous, so it's a very personal decision and one for you to make. As you're looking through egg donor candidates, even if it's an anonymous donor, you receive a lot of information, and we work with agencies from around the country just to help provide my patients diversity of candidates. So you'll receive information on her academic background, her lifestyle, physical traits of herself and her family members, her reproductive history, her personality history. Once you select the donor, then she'll come in for her medical evaluation, her medical screening. Now, you will find first-time donors, meaning she hasn't donated before, and you will find repeat donors. I personally have a slight preference for repeat donors because we have additional information available. We can find out from the agency how many eggs she produced in a prior cycle, how many embryos were created, was there a pregnancy from that donation? What I find clinically is some egg donor patients do very well, make beautiful eggs and embryos every cycle, and others do not. So maybe if we choose this repeat donor, we can decrease the risk a little bit and increase the chances of having a successful outcome. Once the egg donor comes in for her medical screening, it involves genetic screening, She has psychological screening and medical screening before she's cleared to start the treatment process. Before I see the egg donor candidate, she'll have a consultation with a geneticist. Geneticist will go through her medical history and her family tree to look to see if there's any evidence of genetic disease or clusters of disease. Is there a lot of colon cancer, breast cancer? Is there a lot of alcoholism? We're looking for clusters that could be a problem. And this information will all be available for you in your decision making. Everyone has genetic carrier screening, the egg donor and the sperm providers. And genetic carrier screening panels keep getting better and better. 5 years ago, we would test for 3 different diseases. Now we have panels that test for over 200 different diseases. You're tested, your egg donor's tested to make sure that don't both carry a mutation for the same disease. If you have a mutation for cystic fibrosis, we're going to make sure that your egg donor does not have that mutation as well. She has psychological screening to assess her personal history, her motivations for the process, her lifestyle, her general mental status, and this will all be available to you. She'll come in for her medical screening, and in general, an egg donor should be between the ages of 21 and 34 years of age. I'll do a detailed medical and sexual history, looking for any history of sexually transmitted infections that could be a problem. She'll have a physical exam, ultrasound. She'll have testing of ovarian reserve. We want to make an assessment of how many eggs she'll make in a treatment cycle. My goal is always to retrieve somewhere between 20 and 25 eggs to give me a sufficient number of embryos in the process. She'll have basic infectious disease tests for every possible infectious disease. Part of her ovarian reserve screening is an ultrasound of the ovary, and this is an ultrasound image. See all those little black circles? Those are follicles. There's 1 egg per follicle. Every month, the ovaries recruit a group of eggs. In the natural cycle, one is selected to grow and ovulate, and the other ones fade away. In this process, we're going to push all of those follicles to grow and develop. And so the number of follicles we see on 2 is predictive of how many eggs she'll make. And there's also a blood test called AMH that correlates with the number of eggs per cycle. So if she's a first-time donor, we're absolutely going to do an AMH, because if she has a low AMH, she'll most likely produce a low number of eggs, and we'll probably keep looking for another candidate. And then once she's finally cleared, when she starts her treatment, she repeats all of her infectious disease tests. These are called FDA screening labs. And we're ready to start the process. So in the treatment process, we're pushing all those follicles to grow and develop with hormones. The monitoring is very important because egg quality is determined by age, her personal genetics, but also how we stimulate the ovaries. If we give too much medication for too long, we can overcook those eggs and decrease their quality. This is an actual egg retrieval procedure. It's about a 20-minute surgery done under IV sedation. Eggs are aspirated from all the follicles that have developed. They're then transferred to the IVF laboratory, and a couple hours later, they'll be inseminated with sperm, often with ICSI, where we inject 1 sperm into each egg. The next phase, we culture these embryos over the course of 6 days, and we have a continuous culture system where we don't look at them for the first 5 days. And this is a photograph of 2 beautiful blastocysts. So the embryos develop from a 1-cell embryo the day after egg retrieval to over 100 cells, and that's called a blastocyst. So this embryo can be transferred into a uterus, it can be frozen, or oftentimes we'll biopsy it for genetic testing and then freeze it. I want to just present a clinical story of one of my patients to put this all together. Robert's a 40-year-old single man. He wanted 2 children, a boy and a girl, through egg donation surrogacy. To avoid the risk of a twin pregnancy, he wanted a single embryo transfer into 2 different surrogates. He had an open donor. Mary, his donor, is a 26-year-old woman who had donated twice before with about 16 to 20 eggs per cycle. In his cycle, 24 eggs were retrieved. 18 of those were mature. 14 fertilized, and this produced 8 blastocysts. Those are those day 5, day 6, 100-cell embryos. And he did PGS, and it resulted in 4 normal males and 2 normal females. He was matched with 2 different surrogates. Sheila was a 38-year-old mother of 3. She underwent transfer of 1 male embryo and conceived and delivered at 38 weeks. His other surrogate, Beth, a 29-year-old mother of 1, underwent transfer of 1 female embryo, got pregnant, delivered. The babies were born 1 month apart. So he avoided the risk of twins, and he has 2 babies that fulfilled his dream. So egg donor selection, choose wisely, look for someone who you feel really good about, and someone that your doctor gives his or her stamp of approval. So someday, this will be you and your son or daughter walking in Golden Gate Park. Thank you.
Thank you, Dr. Ringler. Now I'll invite Dr. Shriyak to discuss a little more the process of egg donation.
Good morning. It's so wonderful to see all of you here. I think this is the 4th year I've been here, and the crowds getting bigger and better, and I'm so happy. It's been a passion of mine and a commitment that I've had now doing IVF for almost 35 years. So welcome. Hope we can all help you with your dreams. To get started, I'm going to try to briefly talk about the procedure of egg donation, overall basics, a little bit about the medical process, and then we'll get into egg banks, which are kind of a relatively new and exciting option for you all. Dr. Ringler, I think, has talked really well about finding your donor. I'm very supportive of meeting the donor if you're comfortable with that. We have a family therapist, counselor who's been doing this for 20 years and is really good at helping you. It's a free visit that we provide anyone because we think that decision-making and parenting skills that you'll need, you get so much good advice from a professional that's done that. In terms of the process, it's 3 major steps, and that's finding the donor and getting the eggs. The middle step on the screen, the partner donor selection. I think the donor sperm can come from wherever. It's common that you'll have your semen samples frozen, and that we'll use those. It works just fine. It makes scheduling and everything so much easier, and we can comply with a lot of the government regulations for infectious disease screening. And then finding the gestational carrier. A lot of people are now separating these 2 connected events to separate times. Because we're doing so well with frozen embryos, and because a lot of you are going to want to test your embryos genetically, you can uncouple, if you will, making the egg and testing the embryo from then actually transferring it. And it has lots of advantages. You can then relax about finding your gestational carrier. You know what you have in the bank in terms of your embryos to work with. And if you test them genetically, it increases the efficiency of each embryo working in a gestational carrier, and that efficiency can even result then in time and financial savings. So these events used to be coupled. I think Dr. Ringler, let me skip this slide, has talked really well about how to screen donors. I would emphasize that it's a rigorous gauntlet that your donors have to get through. In our particular egg donor agency, of 100 women who call to want to be an egg donor with us, less than 5% make it into the pool. And so face-to-face genetic consults, all those things, carrier screening, I would just echo, all very important. So back to then, do you couple or uncouple the making of the embryo and transferring the embryo? In the old days, we would put both the donor and the surrogate on birth control pills so they would get their periods together. So when the donor collected her eggs, we made the embryo, the uterus in your surrogate is all lined up, the gestational carrier, so that embryo can go right into an endometrium that's appropriate. We still do that, and it's a decision that we would make together. In our program, if you're going to genetically test the embryos, we find that by far the safest, most efficient way to do that is biopsy and vitrify, the new fancy freezing of embryos, and that always is then an uncoupling. And so most people are doing an uncoupled transfer that's done sometime after the embryos have been created. The donor's process of growing eggs is actually fairly simple and straightforward. It's about a 2-week process. It begins when she gets her period. She's in our office on the second day, 7 days a week, for monitoring of ultrasound and blood test. It takes about 10 days for us to grow the eggs. In all women, a certain number of eggs wake up every day, and that's what we refer to as their egg count. That's reflected by what Dr. Ringler said, the AMH. And in a 25-year-old egg donor, when we count her eggs, there may be 20 there. They look like little chocolate chips in a cookie. So if you're ever there and participate in this, we can't make more eggs wake up. We can only get eggs to grow that are already awake. So when we count those eggs in the donor, we are pretty close to predicting how many eggs you might get. So when we're screening that donor, she comes in with an egg count of 5. You and the agency are probably going to get a call. We don't know if this is going to really provide what you want. Now, but let's say that donor is your sister-in-law. She's 35 and her egg count might be that. Well, that's a special exception then. We might go ahead because we know that in some women, they don't make a lot of eggs, but they still have good quality. So we would help you make that decision. But whatever the egg count is, over around 10 days, we expect the little chocolate chips to grow into big follicles, and that's when we do the egg retrieval. The egg retrieval takes 10 or 15 minutes. It's painless for the donor. She gets an IV with some propofol, great stuff, best nap you've ever had. And she'll wake up, the eggs are collected, you'll find out how many you retrieved on that day. We really want to minimize the medical risks for donors, and I think we've gotten really good at that. The thing it used to be is that we, in some donors, could grow too many eggs. It's called hyperstimulation, but with changes in medications that we can use today, the consequences of hyperstimulation have gotten very low. And the other thing I just don't worry about is that it's a long 20-minute talk in of its own, but these medicines don't increase the risk to this donor in the future. She doesn't run into any eggs faster, because those 20 eggs we collect, we're going to die that day anyway. We saved them. They didn't get wasted. And the donor doesn't have any increased risk of cancer in the future. So no guilt trips out there. The donors are doing this. They love it. It's a huge gift that they're providing, and we really want to keep their risk minimized. One of the questions is, how many eggs do we want to have grow as a minimum? It gets into how many babies you want. Is your donor a known donor where we know it's going to be less? I think that our average number of eggs now is 22, and that's a great target. We're not going to get it for everybody, but I think if you start to get less than 10, it starts to have consequences of your cycle success rate's going to go down. It also depends on how many kids you want. Do you both want to use your sperm for half of the eggs? You're almost turning one IVF cycle into 2. So with 22 eggs, 11 eggs with your sperm, 11 eggs with your sperm, and that's a great goal to have, but you probably don't want to have that kind of split if you only have 6 eggs and only 3 in each group. So again, we'll help you be making those kind of decisions. But cycles are rarely canceled in donors for what we call poor stimulation, not getting enough eggs to grow. Repeat cycles, donors in our program have to wait 1 month before they can go through again, and we follow the guidelines of our national organization that they're limited to 6 cycles, with the exception of what's called a sibling cycle. You got pregnant in your donor's 6th cycle, but you come back and want another baby, and then we say that's a sibling cycle. She could go through 1 more time. Donor egg banks are huge. One of the key messages is the only real advantage of freezing eggs and having them in the bank is cost. You can get into an IVF cycle roughly for half the cost. The cost of most egg banks is around $20,000, and the IVF part for a fresh cycle is more in the $40,000 range, so about half price. The important thing when looking at frozen eggs, I always tell is, don't pick a program that freezes eggs. Pick a program that can make embryos from the eggs they froze and babies. So it's not about just freezing eggs. And we've been really proud. Our egg bank's been up and running 5 years now, when we have almost 200 babies born from our frozen egg pool. The egg bank's success rate in our program, an embryo from a frozen egg and a fresh egg have the same success rate. That's huge. Also, in our egg bank, and there's many formats, we also promise you an embryo, not an egg. You can go to an egg bank and just buy eggs, and they'll say, good luck, I hope they turn into embryos, I hope they turn into babies. We feel that we should have that risk on our shoulders, that our eggs are going to freeze, thaw well, and they're going to fertilize well and turn into embryos. So we have what's called an embryo guarantee. And so you can have an egg guarantee or an embryo guarantee. Other things, no, you can have an embryo guarantee for day 3 or day 5. We like to promise 2 day 5 blastocyst embryos from our egg bank. So to compare the programs then of fresh and frozen eggs, I think if you want 2 kids and you know it, maybe the fresh program's better. In our program, out of 2 embryos, you have, each one has a 65% chance, so you have a 130% chance of having 1, but you have to get lucky to have 2. And if you get 1 and you come back in 2 years for baby number 2, that egg donor's eggs are probably gone. You can do it again with another donor, but your kids won't be genetic siblings. So you'll pay 20 and 20, you'll have 2 kids, but they're not genetic siblings, which is cool, that's completely fine. But in the fresh program, we usually get anywhere from 5 to 6 embryos. And then one of your frozen embryos will be baby number 2, and if you're having a whole lot of fun, baby number 3 after that. And so you can then actually make it cost-wise sort of the same if you want 2 children. The time egg banks are a little faster because the eggs are there. There's not a donor to recruit it and get her going. I'm telling myself my time's up here. So let me see. I think I'm almost done. We talked about packets. I think I wanted to talk a little bit about success rates. I think that beware of success rates reported as pregnancies or deliveries per transfer or per cycle start. We've been a big commitment to transfer 1 embryo at a time. And because of that, a lot of our babies come from the second transfer of the second embryo transferred. I think our National Organization of SART has finally changed that data reporting. Because of reporting pregnancy rates per transfer, it prompted the epidemic of twins that we've had in the last 20 years. We've been trying to transfer 1 embryo to almost everybody now for about 10 years. And so I think men having babies is a good example in your program. A portion of our patients got pregnant in their first cycle, which you see, but it's not there that all of them, 100%, got babies from at least one of their fresh or frozen embryos. So again, a way of looking at the data, don't just look at fresh pregnancy per transfer rates. Thank you. I just ran over.
Bear with me for a second. Dr. Shriyak just talked about data from the CDC and SART. So there's 3 websites you really have to remember and consult. One is the ASRM website, asrm.org, American Society of Reproductive Medicine, that gives really meaningful data and information to patients. And Dr. Shriyak mentioned the SART data, S-A-R-T, Society of American Reproductive Techniques or Technologies, gives really meaningful data as with each clinic for the transfer, the success rate per transfer, segregating by numbers of embryo transferred, and also segregating by egg donor versus own eggs. These are really important data to look at. Next, we're going to have Dr. Kumar, who's going to discuss sperm issues. Sperms matter sometimes less than eggs, but still matters a little bit. Thank you.
Thank you, George. And I wanted to start by saying I'm so excited for all of you. I know that this can be a little bit scary, but I think that the hope that this encompasses will bring you great joy and contentment for the rest of your life. So I'm really excited for you. So obviously sperm is a part of the mix of making a baby, and we're going to talk a little bit about things to look for. So I wanted to go back and talk a little bit about sperm production. I know people get a little bit concerned about alcohol or drugs or smoking, et cetera. So it takes about 40 days to 80 days to make sperm. And originally we thought it was about 75, 78 days, but there's some new data indicating it could be as short as 40 days, 45 days. Sperm is made in the testicle and then stored in the epididymis. And those are important things to consider. So previously, 10 plus years ago, we would advise that you save up a little bit and before you ejaculate for whatever you're going to do, either fresh production for IVF or cryopreservation. And now we know that we actually don't want that. So with IVF, with ICSI, we need very few sperm. But what we want is the best quality sperm. So we'd rather have frequent ejaculation so that the sperm that we get are not stored in the epididymis for a while and have been degrading in quality, but we get the freshest, best quality sperm that have been exposed to free radicals the least. Okay. So the very basic test for sperm is a semen analysis, and there are 4 parameters. And the further down we go, the more important they are. We look at the volume, and the volume of ejaculate is mostly made up of fluid that doesn't involve the sperm at all, so the least important. Second is concentration, and we want at least 15 million sperm per ml. And you can imagine that's a lot of sperm. And if we get 25 eggs, like Dr. Ringler said, we only need 25 good sperm. We don't need millions and millions. Motility becomes important because obviously dead sperm or degrading sperm are not going to be usable. And the most important is the morphology, and that's the shape. And if we get at least 5% normal sperm, that's considered good. But if you get less than 4%, that's not good. And that means that in those circumstances, we definitely will have to use ICSI, which is intracytoplasmic sperm injection, where we actually take each individual sperm and inject it into each egg. But along with that, it also means that in those circumstances that it would be more advisable to use a fresh specimen rather than a cryopreserved specimen. So how do we wash the sperm? We initially start with a density gradient. We spin it in the centrifuge, and the dead non-moving sperm and the ejaculate float at the top, and the motile sperm form a pellet at the bottom. Then we wash it several times, and then most of the time we actually freeze the sperm. So about 90% of my patients are from overseas, and they usually come, everything gets separated in time. So they come, we freeze the sperm, do the FDA labs, and then the donor will come through. We get the eggs, make the embryos, freeze the embryos, and then whenever the surrogate is chosen and is available, she'll get the transfer. So it becomes really easy to schedule. There are other tests out there. There's a sperm chromatin structure assay. There's a new test called Episona. I've been doing this for 12 years now. We've had over 1,000 babies born through surrogacy. I don't advise those tests. I think it's a lot of wasted money. With ICSI, we can always find a good embryo. We can always have success. And it doesn't really change the outcome. I wouldn't, if one of those tests comes back abnormal, it's not like we're going to use somebody else's sperm. We will get the right eggs and we'll get the right embryos and make it work. Okay. So as I talked about earlier, fresh versus frozen, the vast majority of the time, frozen is just fine, and it really makes it so much easier in terms of scheduling. But there are some rare circumstances where fresh is going to be more advisable. And that's where the morphology or the count, if it's very, very low, it's highly advisable that you make the effort to produce a fresh specimen. Now, what are the tests that we do? Like I said, semen analysis, cryopreservation, very basic. I do advise a genetic carrier screening, so although the donors are going to go through the same, and most likely you choose a donor that has tested negative for everything, it's also advisable that you go through the testing just in case. Because what is tested are the most common mutations, not every mutation possible. So it's always good to double check. And then the FDA panel is required. Let me see if this video will play here. So this is regular IVF. We can see the big circle in the center is the egg, and then the medium-sized circles are the support cells around the egg, and then the tiny little things are the sperm. I can go to the here. Okay, this is a video of the ICSI procedure. So we can see some poor sperm at the top. The one at the center is the one that's chosen by the embryologist. They actually take the sperm. They're going to break the tail. We'll fast forward. And we've taken the support cells off of the egg. And now the egg is being held stable on the right side, and we see the pipette coming in with the sperm on the other side. That's it. So the question becomes now, we have both partners want to produce and have a genetic child, and we fully encourage that. What are the things to consider? So we talked, Dr. Shuyak talked about frozen eggs versus fresh. And this is an instance where fresh will give you a more cost-effective cycle. If you can get 25, 30 eggs, that means each partner can have the appropriate number of eggs, so we can have good quality male and female embryos. So you can basically decide what you want for your future and have some embryos frozen for another sibling several years down the line. So I think both partners are going to produce, the fresh cycle becomes highly advisable. In terms of the costs, the cost for 2 people fertilizing versus 1 is just a few $1,000s difference, especially if you're going to go through a fresh cycle anyways. Even if you want to do a single embryo transfer, it makes a lot of sense to bank the other embryos so that in the future when you're ready for a second child, it's already there. A frozen embryo transfer is very inexpensive relative to a fresh cycle and paying for another donor. Siblings, I think that of all the things that I've experienced in my life, having my brother has really helped me a great deal. And to have that support is invaluable. And I think that when your children get to be 2, 3, 4, 5 years of age, they're going to ask for a sibling. And to be able to plan for that now, it will make a lot of financial sense in the future. Okay? So, and lastly, the odds of finding the same egg donor in the future is highly unlikely. So plan for it now and freeze the embryos away. Okay. So in terms of the number of eggs that we fertilize, know that the number decreases quite rapidly. So as Dr. Ringler talked about getting 24 eggs and then having 6 normal embryos, roughly 80% of the eggs will be mature. Not every egg that we get will be mature. Not every egg will fertilize. The benchmark is about 80%. Half of those will develop into blastocysts. Well, that's a minimum number. From donor eggs, we expect more. And then finally, at least half of those should test normal. Again, from donors, we normally get about 75, 80%, but that's a minimum. So when you go into it, you want to think about those numbers. Okay, so this is from on the far left, we have a fertilized egg called a zygote, and on the far right, we have a hatching blastocyst. So PGS testing, this I highly do advise. Again, it increases the chance of implantation. This is where, if you think about, most embryos are going to have a certain set of chromosomes. We want 46 chromosomes in each cell, 23 from the egg and 23 from the sperm. But quite often, they can have an abnormal number of chromosomes. And this is not something that's inherited. It doesn't come from the egg or the egg donor or the person providing the sperm. It's spontaneous. So again, nothing that you can test for beforehand, but it occurs spontaneously, so it's highly advisable you do test. And if needed, let's say you choose an egg donor that has cystic fibrosis and you yourself are a carrier, I would highly advise that you don't do it, but let's say that does happen, then we can pick out those embryos that are not affected. So that's the PGD part, but the PGS is just screening for the chromosomes. This is a little video We've taken a laser and cut a hole in the top, and you can see the sampling of the embryo. It's pretty interesting. We'll fast forward through. I think I'm running short on time here. Okay. And okay. Lastly, this is kind of what the results look like, and then you get to decide what you want, boys or girls, 1 or 2. Okay? Thank you so much for your time, guys, and I wish you good luck on your...
Lots of controversies, obviously. Next will be Dr. Norian from HRC Fertility Center, who's going to discuss 2 somewhat unrelated subjects. One is the evaluation of the gestational carrier, and the other one is the evaluation of the embryos.
Well, thank you very much, and I'm very hopeful and very proud of all of you for coming today and getting more information. Hopefully this talk will be informative as the others were as well. So when looking at a surrogate, what are some of the factors that we're curious about? What are some of the factors that we're going to be learning about prior to selecting the ideal surrogate? The first question is going to be her obstetrical history. Remember that all gestational surrogates or carriers are basically required to have had at least a child themselves before. We want to know about that pregnancy itself. Was it a more straightforward pregnancy? Was it complicated? Did she have gestational diabetes or preeclampsia, which is a condition characterized by elevated blood pressure? What was her pregnancy interval? When did she deliver? How many children does she have? Typically, obstetricians, Dr. Silvestre and others, like that interval to be greater than 1 year, where it gives the uterus a chance to sort of recover and regroup. And that, I know that sounds a little bit soft, but biologically it allows the blood vessels, the uterine muscle to develop better with the future subsequent pregnancy. When people have had too many C-sections, the question is how many? Typically providers like myself and others, we like a woman to have had only 1 or maybe 2 C-sections. Beyond 2, I start getting a little bit stressed out, in the sense that I think it makes for a more complicated pregnancy in terms of the placenta potentially sticking and adhering to the uterine muscle in the area of the prior C-section scar. So that could make for growth restriction for the baby and a more complicated delivery. The other is some of the data from the NIH, from our group in Bethesda and DC area. We learned that people who've had too many C-sections, the actual transfer itself may be a little bit more difficult. It's pretty minimal. A lot of us are very particular when it comes to embryo transfer, but it's a factor to consider. And lastly, sometimes mucus or fluid can collect behind the C-section scar in people who've had several C-sections. Medical conditions when looking at a surrogate, we very much want to know, are you healthy? Do you have any medical conditions? Issues with thyroid, diabetes, blood pressure, those are factors to consider. The ideal BMI is that body mass index. It's a little bit controversial, but my ideal surrogate has a BMI less than 30. Beyond 35, I really feel pretty strongly that I don't think that she may be as optimal. Surgical history, has she had other gynecologic surgeries, maybe for endometriosis or other abdominal or pelvic surgeries? Of course, we want to know about her social history. Does she smoke? Or someone in the household smoke, whether it's her partner, a family member. We know very well that a woman who smokes has a lower implantation, lower pregnancy rate. And we see trends where someone close in the household, if they're smoking, we see trends for lower implantation and pregnancy rates as well. So that's something to consider. Family history, like Dr. Ringler was suggesting, we want to know, are there trends? Are there trends of cardiovascular disease or complicated family histories? So that is just a background. So when myself as a physician, we meet, it's sort of getting that medical clearance very much involves speaking with the future surrogate. But it also involves some diagnostic testing. So what are the things we're looking at here? First and foremost, we're curious about the womb, about the uterus. So is this going to be a good vessel for our babies to grow up in? Ways where we do that are oftentimes in our offices, we can do a simple saline ultrasound, where we do an ultrasound and we precisely place a little bit of sterile saline into the uterus, where we can determine, are there polyps, are there fibroids, are there things that may disrupt implantation, even scar tissue? Hysteroscopy is probably the gold standard, where we place a small little flexible camera into the uterus and both see and treat. So if there is a subtle polyp or filling defect, we could remove it at the same time. Hysterosalpingogram is an older technology where we place a little bit of contrast media. Radiologists will do it, and they have a look at both the uterus, but also the fallopian tubes. So if there's a dilated, swollen tube, if a woman's had a history of gonorrhea or chlamydia, sometimes the tubes get a little bit edematous or mean looking, and that's not as ideal for implantation. In terms of laboratory evaluation, a simple thyroid test, a TSH, thyroid stimulating hormone. I will screen everyone for a glucose assessment, a hemoglobin A1C, a lipid panel. You get an idea about a woman's nutritional health based on their HDL levels, their LDL levels, good cholesterol, bad cholesterol. You get a sense of a woman's diet based on some subtle findings from her laboratory studies. And of course, infectious disease screening. Everyone gets a basic ultrasound at the initial visit. This is where we're looking for things like uterine fibroids, which are fibrous tumors. They're benign in the sense they don't spread elsewhere in the body, but they can definitely cause problems as far as implantation. Polyps are small, benign little growths, an abnormal blood vessel where you get tissue that can form over it. Endometriomas are abnormalities where you get the endometrium into weird spots of the body. It's a chronic inflammatory condition, which is not as optimal for a surrogate. And then lastly, uterine anomalies, rare and wonderful things. Certain women can have half a uterus, 2 uteruses, 2 vaginas. Oh my gosh, so many iterations. And being a surrogate, that is the absolute thing we would like to avoid because of the risk of preterm delivery and whatnot. So now, as moving on to embryo evaluation, I know we've heard a little bit about that this morning already. So factors to consider, I want to touch upon embryo grading and then also talk about the role for chromosome screening. Is it indicated? The process of in vitro we've heard about. We stimulate the ovaries, we retrieve the eggs, we fertilize them, and then we let the embryo grow. And then we may or may not do chromosome screening. Typically, the cycle is broken up. Remember that not all of the eggs that we retrieve are going to be mature. About 75% of the eggs are mature. Approximately 70% of the eggs will fertilize normally. And of those eggs that fertilize normally, there's different methods to fertilize the eggs. We heard from Dr. Kumar speak about different methods, whether it's the co-incubation, where you put the egg around a droplet of sperm and you let the best sperm win, a little bit Darwinian, or we better optimize the process where we select the best looking, best moving sperm, the most handsome, and inseminate it directly into the egg. These are pictures of embryos. So this is what we all look like. Every person in the room, we look like this at some point. So we go from that 1-cell embryo in the top left. On day 2, typically the embryos will divide, 2 cells, 4 cells, 8 cells on day 3. Then the process of compaction occurs with beautiful embryonic expansion. So in the bottom right, human embryos typically have 100 to 128 cells. Here's a little video. I hope that it works. So this is a little video of, hopefully, let me see here, I'll do what Dr. Kumar did. It may not. But anyways, I would encourage you, you can even go online or YouTube, and you can see a video of an embryo developing from 1 cell all the way to 128 cells. It's quite remarkable. When we look at the embryos, remember, we're grading them. We're using the Gardner criteria typically, where we evaluate both the size and the shape of the inner cell mass, or the baby portion, and also the outside portion called the trophectoderm, or the placenta. The size go on a scale of 3, 4, 5, or 6, and the letters go on an A, B, C scale. I tend to think the A would correspond with excellent, B would be very good or good. C is a bigger step down, particularly regarding implantation. So when we think about selecting the ideal embryo, the use of technology has really helped aid our implantation success. There's different methodologies, whether we're screening just for chromosome number or for genetic disease. Here, different indications for it. As women get older, folks with fertility, people unlike our patients in this room, will be selecting donors typically who are in their 20s, who are more optimal donors, but it helps us better identify the best embryos. We also learn about the sex of the embryo. I know it says gender. Gender is self-determined, remember. Sex is chromosomal sex. But the rates of transfer, the pregnancy can increase as far as implantation. This is the national data. I would encourage you to look at SART, Society for Assisted Reproductive Technologies. And here is the pregnancy rates for the national data over time. Why does this happen? I know these couple slides are a little bit complicated, but to be human is to have embryos that are not always chromosomally normal. The first column, the egg donor column, here, even in our most favorable patients, 30 to 35% of the embryos are chromosomally abnormal. And this is from a large data set based out of the New Jersey area with national data included. And this is another study that mirrors that, where you can see as women get older, their embryos are more abnormal, more aneuploid, too many, too few chromosomes. But you see here this number in women who are in the ideal donor range, they're still about 30%, 30 to 35% that are chromosomally abnormal. There's been several studies that have looked at this in folks with infertility. Does CCS, does chromosome screening improve implantation rates? The general results for that group of women is that it does appear to improve implantation rates. But the main question is, what about for egg donor and surrogacy? So there have been 2 studies that have looked at this, our group and another group in the US, and it seems a little more controversial. I feel that chromosome screening can be very useful as a way to implant fewer embryos and still maintain a very high pregnancy rate. Putting back 2 embryos that have been chromosomally screened, I think, is starting to deviate from the consistent norms because of this rate of twinning. You can see here that the rates of twins, particularly when putting back chromosomally normal embryos, is quite high. And I know that Dr. Silvestre touched on this a little bit yesterday, but twins are maybe not, or definitely not as ideal. And really what it is this very early preterm delivery. 5 to 7, 8% of twins are born below 32 weeks, where those offspring, those children, will have all the diseases related to very early prematurity. And here, I just want one last little, the gestational, is it necessary? This is a good summary slide just on, I think, PGS. lower miscarriage rates, the live birth rate. I think chromosome screening for egg donors is a little bit complicated. There's a app that I wrote, and other people have written interesting articles on this. You might want to download it. It's quite useful. And I think Susanna is going to talk about that. So thank you very much, everyone. Wonderful.
Thank you, Dr. Norian. One thing I'd like to add also is, like, sometimes when choosing a gestational carrier, there's many shades of gray. Clearly, a patient who had 6 C-sections in the past or had a history of a bunch of preterm birth will not be a candidate. But sometimes it's not so straightforward. I review some cases sometimes of potential gestational carrier who say have a history of chlamydia once or had a history of some bleeding after second delivery, but no transfusions or complications, or a bit of hypertension in 1 of 3 pregnancies. So sometimes it's something that I would say it's okay for her to get pregnant, but say I would really push for 1 embryo transfer to avoid the risk of twins. Sometimes clearly the patient is not a candidate, but I have to say that in the last few years I've seen some surrogates from this group or some friends of mine that clearly should not have carried babies. I'll give you an example. A friend of mine, he had a single embryo transfer. The surrogate's water broke at 32 weeks. So that happens. It's not optimal, obviously. And then he added, well, last pregnancy, she was transferred to that hospital when her water broke at 29 weeks. I'm like, what? She actually had a 29-weeker delivery before, and she's now carrying? That was clearly inappropriate. So don't be shy about asking reproductive endocrinologist, your clinic, your agency, like you'd like your records reviewed by somebody with expertise in maternal fetal medicine. It's certainly not a luxury, I think. I've never seen any of these things happening to any of these guys. They're all excellent clinicians, but be careful. Very good, we're all set. Now Dr. Park is going to discuss embryo transfer and the success rate for embryo transfer, among other stuff. She is working in the San Diego Fertility Center. So welcome, Dr. Park.
This is the home stretch, hang in there. All right, so I'm going to talk about embryo transfer. So let's talk about a fresh embryo transfer, which was already stated is usually not done as much in this patient population, but essentially you select an egg donor from the beginning and a carrier from the beginning. And then using your sperm, we create embryos, which are not frozen. And so because they're synchronized, you can then do a transfer of an embryo that has not been frozen. In contrast, you have a frozen embryo transfer, which means you select an egg donor, you don't worry about the carrier. Using the sperm, you create and you freeze an embryo, and then you find your carrier, and then you transfer. What are the advantages of a frozen? One, it's much less stressful. Okay, because you already know the quality of your embryos. You already know how many embryos you have from which sperm origin. And you don't have to synchronize the carrier and the egg donor, which means that you don't have to go find a carrier now. You know the quantity and quality of your embryos, and it prevents the loss of an egg donor. So you spend all this time finding the perfect donor. And then you tell her, okay, wait, because my surrogacy agency told me I just need 4 more months to find, the surrogate's not quite ready, just 4 more months. That egg donor is going to say, I'm not waiting, because she can donate for somebody else. So it's much easier just to do a frozen transfer. And another common misconception is, well, the quality is not as good as if you freeze my embryos. It's the same, because our freezing technique has gotten so good. And over 95% of embryos survive the freeze and thaw. Okay, so I think if you speak to any physician at this conference, they will all strongly encourage you guys to really do a frozen embryo transfer as opposed to a fresh. So how are embryo transfers done? So they're thawed the morning of the transfer. There is no anesthesia into the carrier. And it's done under ultrasound guidance. Some clinics put the ultrasound on the abdomen of the surrogate, and some people put it vaginally. We just put the probe in the vagina, but it's the same. Maybe not for the woman, but no bed rest versus bed rest. Sometimes we do stuff that's not based on science, right? And so we do encourage bed rest. It is not based on science. It's all really for our mental sanity, but there's really no difference. Okay, and your surrogate's able to fly the next day, but that varies by clinic. So here's a uterus, and you put a catheter inside, okay? And here's ultrasound depiction of what it looks like. This is the uterus, and if you see this white line going in, that's the catheter. And then after you do the transfer, this little white dot is the embryo. You can't see an embryo with a naked eye, but the embryo is surrounded by an air bubble. So what you actually see is the air bubble, which is bright white on an ultrasound. And so here, let's hope the video works, is a video of a transfer. Do you see there's a white line moving? Mm-hmm. That's me. See how I'm going into that white patchy area? See that? Yep. All right. One embryo is going in. See that flash? Yep. I'm pulling out now. And right there. All right, and there's your embryo in your uterus. We're done. Pretty fast, right? So now the transfer is done. This, to me, is the hardest part of your treatment, right? Waiting for the results. Because there's nothing you can do about it now, right? It's out of your control. So what happens? So all these tests can be performed wherever the carrier lives. So let's say like I'm in San Diego, so let's say the carrier lives in New York. She doesn't have to come to our center to do the post-embryo transfer testing. She does it wherever she lives, and this example was New York. So we do a blood test called the beta HCG 10 to 14 days after the transfer. And then your carrier, assuming it's pregnant, it's positive, your carrier then continues vitamins, estrogen, and you'll see that different clinics use different forms of estrogen. It's not right or wrong, it's just different. Success rates are the same. Progesterone, again, different forms of progesterone, and other necessary medications. So let's say she's on thyroid medication, so she'll stay on that. And then 2 weeks after the positive pregnancy test, you do an ultrasound where you can see how many babies there are, did it grow appropriately, and is there a heart rate. So this is an ultrasound of the inside of the uterus. This is called the gestational sac. This little white circle is called the yolk sac, and this little white thing is the baby. Okay, so this is an ultrasound picture of one baby. We call it a singleton. This is a picture of twins, two babies. Notice they each have their own little gestational sac, right? And they also have their own yolk sac. This is a picture of one gestational sac, but two yolk sacs inside with two babies. This is an example of one embryo that just split into two. So this is look-alike twins, and these are not look-alike twins. At 6 weeks, which is usually when the first ultrasound is done, the little embryo is less than 1 centimeter, and 2 weeks later, look how big it is. It's about 2 centimeters, and amazing what it looks like, right? What time did I start? 11:33? Okay, all right, so here is a quick video of the heartbeat. This was baby A. It was a scan on a surrogate. 1.5 centimeters. So I'm measuring the head to the butt of the baby.
Perfect. 7 weeks, 6 days. So it should be give or take 5 days. So perfect. Did you want a copy? Beautiful.
That's the heartbeat. Okay, so success rates. I'm just gave you general numbers because it varies by clinic and it varies by what people just say. So in general, the pregnancy rates will range somewhere between 60 to 90% per transfer. Take-home baby rate will range between 50 to 80. The difference is the miscarriage rate. It varies by the number of embryos transferred. If you transfer one embryo, it can possibly be a decrease in success rate of about 10%, but some clinics report no difference between single versus double embryo transfer. The advantage of one embryo is the less than 5% risk of twins. If you transfer two embryos, it may yield a higher success rate, but your risk of twins is very high. PGS, all I'm going to say is 70 to 80% are normal, as was already presented. And some centers report increased pregnancy rates, some centers report no difference, and no difference in miscarriage rates. Really quick, what is a miscarriage? Biochemical means you have a positive blood test, and then it's negative. Blighted ovum means the blood tests look great, and then when you do the ultrasound, there's a sac, but then there's no evidence of the pregnancy. And a missed abortion means you do an ultrasound, there's a sac, yolk sac, and a baby, but there's no heart rate. So the carrier's not pregnant. She will stop her meds. I'm sorry, in the interest of time, I'm trying to go through my slides. So usually if you're not pregnant, the intended parents, you should just schedule a follow-up with the physician to go over why. The most common reason after one unsuccessful embryo transfer, honestly, is bad luck. Okay, and most of the physicians will say, obviously they'll review the treatment cycle, but if everything looks good, they'll usually say, I think you should try again. But if the carrier's not pregnant, again, everyone is angry and pissed off, right? Everyone, obviously you guys are, but so is the clinic, the agencies, the carrier, okay? So things to look at are the egg donor, the quantity and quality of the eggs. Was the protocol appropriate? Is she a proven egg donor? Looking at that was the egg donor. Looking at the carrier, did her uterus develop okay? Did she take her medications? Do we need to repeat the uterus study? Dr. Norian mentioned hysteroscopy. And if you're doing these crazy tactics to try to increase implantation rates, I always ask intended parents, is this a worthwhile carrier? Maybe it's time to find another carrier. The sperm, you guys don't get off the hook that easily, right? So we look at the quality of the sperm, and if there are two sperm sources, compare the embryo development. Okay, because if one of you has much better embryo development, maybe it's really the sperm source. If the carrier is still not pregnant, look at the center, the IVF lab that you're using, right? Because it's not like everybody's perfect every single time. So things to do is considering PGS. If you had not done PGS on the embryos, one option, increasing numbers for transfer, special testing on your carrier, transfer the embryos from the opposite sperm source, create brand new embryos using a new egg donor, or changing fertility centers. But the bottom line is repetitive lack of success is very rare. Usually you guys will be successful, if not in the first and the second transfer. Okay, thank you.
Great medical presentation this morning. Thank you, everybody. One thing to remember is like, you read these blogs, these Facebook pages, and it seems like everybody is successful from the first try. Not so. A lot of us were not successful on the first try. I was never successful on our first try. And you know, the stories you mentioned really happened to me. Like our first transfer didn't work, then we got successful with second transfer for our first child. Done deal. 3 years later, we want to have another child. We tried the same carrier. After one failure, one chemical pregnancy, and a third failure, we decided to move on, sometimes into a different carrier, and it worked the first time. Importantly, I totally forgot about this. It was very stressful, but 4 and 7 years later, I do not remember. And I keep myself reminding that if the transfer had worked, I wouldn't have the kids that I have now. And the kids that I have now are the best kids in the world. Yeah, like I said, we just moved on carrier, but does the science explain why it worked for her the first time versus it failed 3 times? We don't know. There's still a lot we don't know in IVF science and reproductive science, but empirically speaking, sometimes it's just better to move on. So do we have time for questions? No time for questions, I'm sorry. So we're here if you have to ask us questions, ask these guys questions individually.
All right, once again, I'd like to thank our medical panel. Thank you guys very much today for the session. So we're going to conclude this portion of the event, and we're going to switch gears, and I'm going to bring up the gold sponsors for the event and introduce them. And then after that, I'll cover some housekeeping items and release you to lunch because I'm sure that people are hungry. And then there's other things that are going on as well. So thank you guys very much to our medical panel. And I'm going to bring to the stage Jay Cook from Same Love Surrogacy.
Hello, everybody. My name is Jay. I'm with Same Love Surrogacy. We are a full-service surrogacy and egg donor agency, and we're located in West Hollywood, California. We're so excited to be here. I love coming to San Francisco. It's one of the biggest turnouts for men having babies, and it's got the people here are just really great and amazing. So just to tell you a little bit about us, we are a gay-owned and operated agency owned by gay dads of twins. So we've been in your shoes, we know what it's like, we've been through the process ourselves. So we find that that's very helpful because we know what you're going through and we understand. We have special pricing for our clients with our preferred vendors, and which is very helpful, and so it helps lower the cost and keep things down for you. We also are a part of the GPAP program, so we're very proud of that, offering those services this year as well. And we're really, really proud of the fact that we're at the top of the ratings for the Men Having Babies survey. So we're pretty excited about that. We've been working very hard to have good scores and do a good job for our clients. You're working directly with one of the owners throughout the process. You're not passed off to coordinators and employees. You have our direct numbers, our direct contacts. So if there's ever an issue or a problem, we're going to take care of it immediately and be right there. So lastly, we're going to have a breakout session today at 2:50 and 3:10 in the Heritage Room right over here. So we look forward to giving you more specific information. Thank you so much.
And I'd like to welcome to the stage Dr. John Norian from HRC Fertility.
Hi, everyone. So it's nice to speak again quickly. I am from Southern California. We have two offices. I'm in Pasadena and also in Rancho Cucamonga, which is a little east of our Claremont colleges. We are a full-service reproductive practice. HRC is the largest reproductive practice outside of the East Coast in the United States. But all reproductive care is very granular in the sense of the doctor, patient, egg donor, surrogate relationships. Myself and my team very much take pride on all of the particulars related to fertility care. I do a little bit unique in the sense that I do all of my own ultrasounds, all of my own retrievals, and all of my own transfers, about 98, 99%. So I'm very involved in the process. We very much pride ourselves on our success rates and helping many different people in our greater community, whether it's single males, same-sex couples, or others in our LGBT family. I'm a board member of the Path to Parenthood, which is another wonderful organization that helps people navigate the path. Our website's really neat. I'm also right now was elected to the SART Registry Committee. So remember that Congress required that we report our outcomes. We all do our bit. I'm sure each of you do in your own field. And being involved nationally allows us to have a voice. And me and my colleagues really allowed SART to report folks with LGBT community, which is wonderful. So we've got a wonderful team here. Come visit us. Ashley and Deanne, my coordinators and nurses, are here, and I'm so happy for you beginning this journey.
Thank you. And now Sam Conley from Northwest Surrogacy.
Wow, it's really wonderful to see all of you here, and thank you so much. I'm so excited to see so many future dads. My name's Sam. I'm from Northwest Surrogacy Center, and I'd really like the chance sometime today to sit down and talk with you about how my family helps people like yourselves build families. 24 years ago, my father and stepmother founded Northwest Surrogacy Center. Makes us one of the oldest and most well-established agencies in the country. We have an office here in San Francisco, although we are based out of Portland, Oregon. We have an associated law firm that's housed in the same building. There's a lot of things that we're focused on, but perhaps the best thing that we can do for you is talk with you about how our agency increases the probability that you're going to be successful with the first surrogate that we match you with. Surrogacy is imperfect, as you've been learning, but definitely looking at those probabilities and other ways to reduce risk is what we specialize in. We're also excited about a project that we recently started, which is an egg donor database focused on Asian donors, which is kind of a tricky area to figure out. So that's something we'd also be more than happy to speak with you. We're going to have a couple of breakout sessions this afternoon, so please come to those. Please also come by our table. And also, if you can't make that, we'd love to make an appointment with you to meet here in our San Francisco office. And enjoy your day, and I hope that all of you really learn a lot about building your families.
And now Dr. Ashim Kumar from Western Fertility Center.
Hi, everyone. It's good to speak again. I wanted to tell you that we have full-service IVF. We do everything from egg donation to surrogacy. We started the clinic about 2 years ago. I've been doing this for 12 years, but I started my own place because it's not just having success, but also how we achieve it. I really want everyone to have the most positive experience possible. This is one of the most important paths that you'll take in your life, one of the most important journeys. And not only does it need to end in a healthy baby, but it also needs to be a positive experience overall. So that's what we want to focus on. We've had over 1,000 births from surrogates. We work mostly with clients from all over. Like I said, 90% of my patients are from overseas. It's actually a really easy path in terms of choosing egg donors, choosing surrogates. So we work with many agencies from our global egg donors. We can get donors from all over the world. And surrogates, like with Same Love, we work with them closely. Brad and Jay, I think I talk to them every other day, in fact. So the path actually is really quite easy. It's a favorable outcome for all of you. And I think the scariest part is just getting started. So maybe let go of the fear and embrace the hope. So I wish you guys luck. Thank you.
And now from CRM, Dr. Tezuki, Dr. Moyari, Dr. Ming, and Dr. June.
Thank you. Hi, everyone. Good morning. Want to congratulate and thank the organizers for this is an amazing, informative, comprehensive conference. I've been very impressed. And we are so honored and privileged to be part of sponsoring and being part of your family building journey. CCRM stands for Colorado Center for Reproductive Medicine, started by Dr. Schoolcraft in 1987, and they have been focused on helping building family dreams come true for 30 years. He was actually, and his embryologists are the first ones to characterize that whole blastocyst culture. They have been pushing the frontier for fertility for a long, long time. And they started building network of centers. So myself and Dr. Jun are in San Francisco, Dr. Moireri and Dr. Meng are in Orange County, and there are also 8 other centers, including Toronto. So we can facilitate complex navigation of surrogates, donors in different locations by having the power, as well as offering one of the highest success rates in the country. So we hope you come and visit us in our expo upstairs, and really love to be part of your journey. So thank you so much.
And from Create Fertility Canada, Near Kieran.
Hello, everyone. So my name is Nir, and I keep hearing all the presenter here are sitting, standing and talking about their clinics, and I'm sure that no matter what you're gonna choose, you're gonna have great experience, and you're gonna end up with expanding or creating your families. What I came to tell you is something that is a bit different. It's a bit a different journey. It's a Canadian journey. The biggest difference is other than going up north to a different country, which people are super nice. The biggest difference is that the cost of the whole journey will cost you almost half of what it's going to cost you to do in the United States. So we're looking at almost half price to get the same end results. So it's something that I really encourage you to come and explore. We are the biggest clinic in Canada. We have the largest egg donation and surrogacy program, so we kind of know what we're doing. We're helping everyone throughout the process. From my experience and other experience, this journey is so expensive so if you can actually have the cost without jeopardizing anything, the healthcare is pretty good in Canada. It's not like we're going to places like India or Mexico. Then it's something that you definitely want to explore. We work with all surrogacy agencies in Canada and United States, so we can offer other solutions. We have a breakout session today at 3:30, which we're going to show a video that was done by the documentary channel of Canada. So it's a non-biased one that shows how the process works as a long-distance process for surrogacy in Canada. So I really encourage you to come and see it. It's worth the $60,000 that you can save. Okay, and come see us at the booth. We'll be happy to tell you all about it. Okay, thank you guys.
And now, Dr. Shryak from Pacific Fertility.
Thank you very much. I shared a little bit earlier when I spoke that this has been a part of my career that I have both professional and personal, passion about. I've been doing IVF for 35 years, and I started supporting gay couples 25 years ago in a very serious way, holding conferences and everything. So to see this to me is wonderful. With that track record, though, I think I've also seen what it takes to build a program that can make all of our goals come true. And I think part of that is a team. You're learning that there's a huge team involved in this. And I think facilitating all of the pieces of that team to work together. Sometimes I think I'm a general contractor. I have all these subs that I got to do to build your family. And so I think doing it for a long time and putting that kind of team together supports you in so many ways. I think you have to have a program that you really feel you can communicate with. Someone where you can ask serious questions, open up the fears of your heart and be able to be reassured and feel that one of my goals is to not make decisions for you, but to make decisions with you. To do that well, I have to educate you, and being a professor for years and years, I've learned that that's really important. And I think finally, this technology is flying fast, and it's been a great ride for me professionally, but to keep a program that's on the cutting edge scientifically is critical. And I think some of the keys to pay attention to are vitrification. The new successful fast freezing of embryos is wonderful. We lose less than 2% of our embryos now when they're thawed. That's awesome. Having a lab that can keep your embryos happy. They're in that embryo hotel for a week, in our lab up to day 7, which I think is an important thing to learn about labs. And also the embryo testing, that's a pretty technical thing to do. So having a lab that's great is really probably the key piece in addition to the interpersonal. So good luck, everybody. Hope you all win. You will.
And now Donna Rady from Fertility Source Companies.
Hi, you guys. There we are. Welcome to San Francisco. For those of you who don't live here, it's a super exciting venue because they have so many. This is the biggest turnout that I think I've been to. We've been doing Manhattan Babies for about 5 years now, so this is really exciting. I know you guys are like overwhelmed. Your heads are exploding. You're all hungry. We're a full-service agency. We've been around since 2003. We're upstairs. We'd love to meet with you guys and talk with you. You're going to have thousands of questions. I can't possibly introduce my company. I think we're fantastic. Hopefully you guys will come talk with us. We can show you we're fantastic. Enjoy your lunch. Come and talk to us upstairs. We love love to help you guys. Thanks.